And our goal at Lume is to enable the existing and impending wave of transcatheter therapies requiring large bore access with a standardized method for large bore femoral vascular closure. So our clinical case scenario generally starts with an aging patient coming in for an endovascular aneurysm repair, and his physician goes ahead with the large bore repair via a transcatheter-based solution. We've got these new valves, these new grafts, but we're using 90s era technology to close these large bore access sites. And this technology was designed for small bore holes. So we're using these devices in duplicate, triplicate, sometimes up to 4 devices to close these large bore sites that were designed for small bore closure. And pardon the graphics, but this is the result when those devices fail. We see the type of calcium in these aging vessels that precludes the use of small bore closure devices in about 2/3 of patients. And it lands patients in the hospital for an additional 2, sometimes 3 days. And it increases the impact of the procedure, what was supposed to be a minimally invasive procedure, on the patient, and of course the cost to the hospital. So the issue we're seeing is that these novel transcatheter therapies, valves and grafts, are plagued by closure complications. So our problem is that current closure technology is limited. We are not applicable for calcified closure of these vessels, and we can actually cause damage by attempting to use those vessels. So our gold standard is that surgical cut down. So this requires a vascular surgeon to come in after the cardiologist has done their work and perform the manual closure of the vessel. And what we identified at Lume is a novel surgical predicate, which is still a surgical technique, but it's slightly less invasive. It's called the fascious suture technique. And it's, again, less invasive than an open cut down, but it still enables a bailout for when these devices fail by obtaining hemostasis of the access site with a novel approach. And the way this works is by leveraging the anatomy of the femoral triangle in the groin. So there is a series of fascial layers, connective tissue, that you pass through on the way into the vessel called the fascia lata and the femoral sheath. So when we perform a transcatheter procedure, we're passing through these layers on the way into the vessel. Using that access sheath, we'll deliver the devices. And upon completion of the case, we can actually throw a U-stitch around that access sheath, and on the way out, we can cinch that knot down. So we're controlling the bleeding, and we're providing watertight hemostasis within a control volume of connective tissue within the femoral triangle. The technique has been validated in 6 prospective cohort trials and 1 randomized controlled trial with a 96% efficacy rate, which is on par with the closure devices, as well as the surgical closure that we would perform with a surgeon. And essentially what we're doing is just adapting this validated technique into a percutaneous device and reducing the skill level required to perform the technique. So when we compare the surgical method with the device-based approach, of course we're reducing the time it takes to close the access site and obtain hemostasis, but more importantly, we're reducing skill level from someone trained in vascular surgery to all of interventional cardiologists, all interventional radiologists, and anyone implanting a large bore device. And of course, we're reducing the impact on the patient. We can get that patient out of the hospital with an outpatient procedure as opposed to those extended inpatient stays. The technique actually depends on bipedal anatomy, so we're not able to use a quadruped animal model. So in order to evaluate our device and develop it, we're using a pulsatile cadaver model where we can cannulate the patient as we normally would. We have accurate anatomy and an accurate clinical case scenario with which to develop our device. So of course, we're competing against the existing closure landscape of devices, which consists primarily of the transarterial suture-based devices. So these are plagued with, again, the type of bleeding complications and damage to the vessel that we see with the use of 2, 3, 4 of those perclose devices. And they're not only that, but they're difficult to learn how to use. It takes about 25 cases to get comfortable with them. The plug-based devices are a second class of devices that have recently been adapted for large bore closure. The problem with these is they introduce a large foreign body into the intravascular space and can actually inhibit the ability to re-access the vessel. A lot of these patients are coming in for additional procedures down the line. And when there's a large bulk of foreign body in there, it's difficult to get access to that vessel again. They can also be plagued with infection. And by sort of backing out, allowing the vessel to heal itself within this control volume of connective tissue, we are allowing nature to do its own work, and we're enabling faster recovery of these vessels by leaving foreign bodies out of the intra-arterial space. So the regulatory pathway is well established. We've seen a number of closure devices. We know what the endpoints look like. We know what the trial sizes look like. And our market is expanding. So this calcified large bore access. There is no closure device that can accommodate these clinical cases. So this is sort of our beachhead market. We're targeting all of large bore access following that beachhead, which is about $600 million. And ultimately what we see for this device is a universal closure device, which eliminates the intravascular foreign bodies left behind by existing devices and applies a universal approach to closure, which allows the vessel to heal itself naturally and enable reaccess in the future. So as we mentioned, we have an established foothold of transcatheter therapies in aortic valves and aneurysm repair, but mitral is also a large growing segment of this market. Between 13 and 25% annual growth rate we see across these major categories of endovascular repair. Several closure devices have been acquired in the past few years, and we've seen a ton of activity in the aortic and mitral space in the previous few years. So hospitals actually lose money each time they do one of these cases because they've got extra days in the hospital. And so by converting a surgical closure to percutaneous, we're saving hospitals up to $3,000 per case. Physicians are also incentivized to use these devices with add-on codes that they can use once they finish the case. We're grateful for the funding and support provided by the Stanford Biodesign Program and a number of competitions and grants on our way to becoming a company in residence at the Fogarty Institute for Innovation, led by the inventor of the balloon catheter, Dr. Thomas Fogarty, which is supporting us as we finish our preclinical work. And we're seeking support and partners as we develop this technology up to first-in-human trials. We're looking for a $1.5 million seed round and to get this thing through to first-in-humans. So our team is comprised of engineers and surgeons and interventional cardiologists out of the Stanford Biodesign Program. And we have an excellent advisory panel with experience in closure space in the past, vascular surgeons who are intimately connected with the issues that arise associated with the use of current devices. And we're building a strong IP portfolio with our legal counsel.